online session. And today we have two eminent examiners with us, Dr. Chinmayi, Professor and Consultant, Department of Pediatric Ophthalmology and Oculoplasty in Minto Eye Hospital, and Dr. Sheetal, Professor and Consultant, Department of Ophthalmology, Enepoya Medical College. It's a fortunate thing that we are having them with us with these two cases which we would be discussing today, which are anterior uveitis and the lid coloboma case. So to present these two cases, we have with us Dr. Shruti and Dr. Dhaneshwari with us. So the first case which would be presented would be lid coloboma case, and I request Shruti to start sharing her screen. Please put on your video and start presenting your cases. So first, Dr. Shruti would be presenting lid coloboma, followed by that Dr. Dhaneshwari would be presenting anterior uveitis. The last half an hour, as the PG who was supposed to present the macular hole has some emergency at home, would be a perimetry tutorials by Dr. Krishna Prasad sir. So over to Dr. Shruti. You can start your lid presentation case now.
Okay, ma'am. Ma'am, can you able to hear me?
Yes, we are
Yes,
able to
Dr.
hear
Shruti.
you.
Yes.
Can you make it into PPT mode, Shruti, so that it will be fully maximized? The slideshow mode.
It's in slideshow mode only, ma'am.
Go ahead.
Good evening, everyone. Today, I am presenting the case of Master ABC, 45-year-old male.
Shruti, can you just press F5? To press F5, it will go into slideshow.
Or on the right hand below side, you just beside the volume, you have that projector scene. Set that icon, that also if you present, it will go into slideshow. Right hand, right hand, your cursor, bring it to the right hand side below. Volume, if you are able to see the volume, maximizing part of the last but one. Come down, fully down, your cursor, right side.
1 second, sorry, 1 second, ma'am.
It's okay. If it is too difficult, you can just start presenting.
Ma'am, can I present?
Yes, Shruti, you can start.
Okay. Presenting the case of Master
You have
ABC.
not started screen sharing. Your PPT is not visible to ma'am.
Okay, 1 second, ma'am.
Share screen, Shruti, share screen. Yes. Start presenting, Shruti, or muted. Unmute and start presenting. Unmute yourself, Shruti. Dr. Shruti, are you there? Shruti, are you there? Dr. Shruti, we are not able to hear you. Can you please unmute yourself? Yes, unmute yourself. You're on the right button. Unmute yourself, Shruti. I'm able to see what you're doing. You have anybody with you, Shruti? Oh, God. You stop sharing, Shruti. Please press the stop sharing button. Yes. Now unmute yourself now. First unmute yourself.
Yes, ma'am. Now you are able to hear?
We are able to hear you. If you're not able to share the screen, don't worry. Start presenting the case.
Okay, ma'am. Good evening, ma'am. Presenting the case of Master ABC, 45-year-old male, clerk by occupation, residing in Hubli, came with a chief complaint of defect in left upper lid since 3 months, watering in left eye since 2 months. Coming to history of presenting illness, the patient was apparently all right 3 months ago when he had a fall from the bike and suffered trauma to his left upper lid. The patient was started on topical ointment for the same and was told about the need for a surgery by the local ophthalmologist. The patient also complained of watering from his left eye since 2 months, for which he was using topical lubricating drops. There is no history of diminution of vision, no history of ocular pain, redness, discharge, photophobia, no history of any intraocular surgeries. Medical history, no history of any systemic illness. Birth history, no significant birth history. Family history, no significant family history. Personal history, diet mixed, sleep and appetite normal, bowel and bladder habits are normal, no addictions. Treatment history, the patient is on topical lubricating drops and ointment. Coming to general examination, the patient is moderately built and nourished. He is conscious, cooperative, well-oriented to time, place, and person. His vitals are pulse rate is 80 beats per minute, respiratory rate is 18 breaths per minute, and blood pressure is 130 by 78 millimeters of mercury. No signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. Coming to systemic examination, cardiovascular system, respiratory system, CNS and abdominal system were within normal limit. Coming to ocular examination, head posture is normal, ocular alignment is normal. Ma'am, I would like to present the findings of left eye first. Coming to the left eye vision, uncorrected visual acuity, 6 by 9 and N10 using Sneller's chart. And the best corrected visual acuity is 6 by 9 N6 with plus 1.75 diopter. Coming to the lid examination, there was a full thickness upper lid margin defect involving the middle and lateral 1/3 of the eyelid, measuring 15 into 3 mm in size. Conjunctiva was normal, cornea normal in size and sensation, inferior and central cornea exposed on lid closure, iris normal in color and pattern, pupil round, regular, reactive to light, lens is clear, anterior vitreous is normal, intraocular pressure is 14 mm of Hg mercury at 11:30 am using Goldman applanation tonometer. Ocular movements are full and free. Coming to right eye, vision was 6 by 9 and N10, best corrected visual acuity with a 1 plus 1.75 diopter, 6 by 9 N6. Lids are normal, conjunctiva is normal, cornea is normal in size, leisure, transparency and sensation, iris normal, color and pattern, pupil is round, regular, reactive to light, no RAPD, lens is clear, anterior vitreous is normal, IOP is intraocular pressure is 18 mm of mercury at 11:30 am using Goldman applanation tonometer. Ocular movements are full and free. Coming to fundus examination of the left eye, on distant direct ophthalmoscopy, red glow was present. In slit lamp biomicroscopy using 90D lens and indirect ophthalmoscopy using 20D lens, media was clear. Disc was normal in size, shape and color with a vertical CD ratio of 0.3. dichotomously branching vessels with an AV pattern of 2:3. Foveal reflex present, background retina was normal. Coming to right eye, distant direct ophthalmoscopy, red glow was present. On slit lamp biomicroscopy using 90D lens and indirect ophthalmoscopy using 20D lens, media was clear. Disc was normal in size and shape and color with a vertical cup disc ratio of 0.3. Dichotomously branching vessels with an AV pattern of 2:3. Foveal reflex present, background retina normal. My provisional diagnosis is right eye presbyopia, left eye acquired traumatic upper lid coloboma and presbyopia.
Shruti, can you please tell a little bit about the injury? Like after the injury, what all was done immediately?
Sorry, ma'am, your voice is breaking.
No, can you hear now?
Yes, ma'am.
Yeah, so right after the trauma, what were all the immediate things done to the patient? Like in the primary hospital,
Okay.
what were the medications given and what was done to cover the defect or any surgery was done at that time?
Yes, ma'am. The patient was advised for surgery, but patient was not willing for it. So the local doctor has treated him with antibiotic ointment, lubricating eye drops, and he was advised for surgery, but he was not willing for that.
Okay. Any particular reason why he refused the surgery? Because involving the upper eyelid, and considering that he could go into an exposure keratopathy, what are the factors generally? Why do you think this patient particularly did not develop any exposure keratopathy in spite of having such a large defect?
Ma'am, exposure keratopathy was there in the left eye on examination. Inferior and central cornea was exposed. So
Okay.
signs of exposure keratopathy was there.
Okay. So 3 months, this particular patient did not take any treatment for
He
the same.
was using on topical lubricants and ointment.
Okay. What is the Bell's phenomenon in this patient? Like, how do you grade Bell's?
Bell's phenomena in this patient, it was upward and laterally. It was poor. Like Bell's phenomena, we can grade it into like 3. So if the we will ask the patient to close the eye, and if we try to lift the eyelid while telling the patient to forcefully close the eyelid, usually in the normal person it's a good Bell's. Like it will go upward and laterally. So usually if it is covering less than one third of the if it is covering more than one third of the cornea, it is like a good Bell's. If it is covering one third to one fourth, it is moderate Bell's, and it's covering less than one fourth of the cornea, and it is poor Bell's.
Okay. Was this patient advised to patch his eye at least when he refused the
Yes,
surgery?
like overnight patching was advised.
Okay. So can you briefly describe once again the defect?
The defect was involving the upper eyelid margin, involving the middle and the lateral one third, and it was a full thickness defect measuring 15 mm into 3 mm.
Okay. When you tell full thickness, can you elaborate on the layers of the eyelid? Like
Um,
lamella of the eyelid, anterior and posterior,
uh,
whatever.
eyelid, it consists of an anterior and posterior lamella. So anterior lamella consists of skin, subcutaneous tissue, orbicularis oculi muscle. The posterior lamella consisting of tarsal plate and conjunctiva.
Okay.
So it was
So,
a full thickness involving both anterior and posterior lamella.
okay. So in this particular patient, there was a tissue loss when he
Yes,
presented.
yes, ma'am.
Okay. Did the patient try to search for the lost tissue? Like, do you think if they had come, if they had found the lost tissue and it was repaired, would it take up?
Sorry, ma'am, I didn't get you.
No, like if the patient, the tissue was lost, right? The middle
Yes,
part
ma'am.
of the upper lid, it was lost. So, do you
Okay.
think if the tissue was found and you had attached, would it have survived?
No, ma'am. Since it is a three, like immediate if they presented.
Correct.
I
So
don't
if
know.
it was a immediately if it had presented when the tissue has not lost vitality, uh, it could have preserved. Like, if you had re-sutured it, it may sometimes revascularize and take up. Okay.
Okay,
Uh,
ma'am.
so the thing is like anytime when there is a trauma, even if the tissue is lost, you should still try to search for the tissue and attach it. Okay.
Okay. Okay.
Okay. Now tell me what are the other causes for this kind of coloboma of the upper eyelid? How do you classify the coloboma of the upper
Coloboma can be congenital and acquired.
eyelid?
So, congenital can be isolated or syndromic. It can be associated with syndrome. Acquired can be like traumatic or it can be surgically induced post resection of the tumors.
Okay. So if given a choice for you, upper lid coloboma or lower lid coloboma to repair, what would you take
Hmm.
and why would you choose? Which is easier and which does not cause a lot of problem?
Upper lid coloboma has to repair first
Correct.
because
Very good.
it
Why?
can lead to corneal exposure keratopathy and cause problems.
Yes.
Lower lid coloboma, there are like post repair, like there are chance of ectropion, uh, like
Correct. So always upper lid coloboma has to be repaired. The lower lid coloboma you can come and it can be long term. Like many of the basal cell carcinoma, particularly in Australia and other conditions, other countries, many people just remove the tumor and leave it, particularly if it's an old patient. But upper eyelid coloboma always has to be repaired. Okay.
yes, yes.
So, what are the surgical options for this particular? Like
So,
what are the
surgical
options?
options will depend upon the amount of defect present. So, since in this case, if my defect is like 15 mm into 3 mm, so it's like full thickness defect more than 50% it is involving. So, we can try Cutler Bay technique or semicircular tensile flap repair,
Yes.
tensile flap
Fine.
reconstruction.
Okay. So suppose this defect was in the medial part, what procedure would you have chosen?
Defect is in the medial part.
Yes.
Like
Because it is in the lateral,
chance,
you told tensile flat. If it is in the medial part,
medial part we can take paramedian forehead flap or
yes,
glabellar tap.
yes. Very
Glabellar
good,
flap.
Shruti. So even the defect is in the medial, you can do a globular or a nasojugal flap. Uh, suppose if
Yes.
this is your patient is very young, so if your patient is very old, then anything else would you try even for this large flap? Can you try anything else, medial or
For,
lateral, whatever?
for older
Yes,
patient.
older patient.
Uh,
So it is if a patient is older, then the tissues are more lax, right?
lax, yes.
So yeah, you can also do a lateral cancer cancer like this and do a
Uh,
sliding. Okay, you can slide and try for direct approximation.
okay,
Okay.
ma'am.
So,
Okay.
like you told earlier, one of the factors that decide what surgery you would do is the amount of defect, whether it is
Mm.
one third, 50%, more than 50%. And the other thing is whether it is area, whether it is the medial, middle, or lateral. Okay.
Yes,
And
yes,
then the other thing is the laxity of the tissue, whether your
yes.
tissue is tight as in a young patient or is it lax. So these are the three things that we consider. The fourth thing is whether it is a partial or a full thickness.
Full
Okay.
thickness.
So
Yes, ma'am.
among all the things we put in and then we decide which flap would be good. And like you rightly told, this particular patient, we can do a cutter bed or we can do a tensile flap,
Oh.
semi-tensile flap. So which one would you consider between the tensile and the cutter bed procedure? What is the better procedure?
Uh, I would like to do a Cutler bed.
Yes. I would also try to do a cutter bed case. Any reasons like why you want to do this surgery for this?
It's involving the upper lid, and the defect is more. It's nearly around 66 percentage. So
Yes. So in your dental flap, you have to take another tissue for your posterior lamellar reconstruction. Like you may have to take a ear cartilage or a buccal cartilage, right? But
yes,
in your cutler bed procedure, all the tissues come from the same side. Like skin, your tarsal bed, and everything comes from the lower right. Okay.
yes,
But so, and particularly for your upper lid repair, you definitely have to have the posterior lamellar reconstruction because
yes, ma'am.
it has to also give the tear film and the it has to act as spreading the tear film also, and
Uh,
you need certain amount of tensile strength for the upper. For the lower eyelid, even if you do not put the posterior lamella, it is still fine. But for upper
yes.
eyelid, both posterior lamella has to be repaired. So tell me what are the options for your posterior lamella? Where all can you take graft? So one is your cartilage, I mean like your tarsal plate from the lower eyelid. Then I told cartilage. So where would you harvest cartilage?
Um, like for the posterior lamella,
Yes, yes.
post like membrane.
Yes, you one is the mucous membrane and the tarsal plate. So for your posterior lamella consists of mucous membrane and cartilage. So instead of conjunctiva, what are all the, now I'm just discussing what are the alternatives for skin, what are the alternatives for your uh, cartilage, and what are the alternatives for the mucous membrane in general. In general.
Uh, I'm not sure, ma'am.
No, no, just don't get tense. So for skin, okay, if you want to do a skin graft, where all can you take skin from? Which matches the skin color? We can take from the opposite eyelid, right?
Yes, ma'am. Opposite eyelid.
Yes. Then where if the defect is very large,
Pre-auricular.
yes, very good.
Pre-auricular.
You can take pre-auricular, then
Um,
post-auricular you can take.
supraclavicular area.
Supraclavicular area, very good. Then you can also take from the inner arm if the defect is very large. Okay. But
Yes, ma'am.
whenever we have very large defects, you have to take skin which is very large, and that's most of them inner arm. So many of the times your plastic surgeons and all take skin from thigh, which is not a very good option for the face. Particularly when the patient is young, they would have taken the skin. And when the child becomes older, the hair starts to grow. Okay, so
Yes.
the skin has to be hairless, and it should the quality of the skin should match with the facial skin. Okay?
Yes, ma'am.
So
Yes.
next we go to the second middle layer, that's the cartilage. So that cartilage you can harvest from the ear again. If you're taking the post-auricular skin, you can also take the cartilage from the skin. Okay, and you
Yes.
can also take the septal cartilage. We can also harvest from palate, hard palate. So these are the three things for your like for the middle layer. And for your mucous membrane, you can use conjunctiva or you can use the buccal mucous membrane.
Yes.
When both are not there, you can also use multi-layered amniotic. Okay.
Yes, ma'am.
Okay. So can you just briefly
Hello.
can you tell the cutler bed procedure, steps of your cutler bed procedure?
So, in cutler bed procedure, we will first we will measure the size of the defect. So, according to that, we will plan an incision in the inferior eyelid margin, just 1 to 2 mm below the inferior tarsal border, and vertically around 1 to 2 mm incision. And we will dissect it till fornix, and we will advance that flap and sutured with the upper eyelid defect. Like it is usually done as a two-stage procedure. So after 6 to 8 weeks, we will cut that flap, leaving that conjunctival side more so that it can wrap it around and form the margin.
Yes, very good. Like what like you told, the conjunctival side has to be long because finally the skin should not rub on the cotton. So
Yes,
your
ma'am.
conjunctival should be longer. So the lid margin finally should be good. So during this interim period, how do you check the cotton? Like how do you know the certificate? Or if already there is exposure, how do you check the ulcer?
Um,
So we
I'm
just ask them to look to the sides and slightly you can open and keep checking and keep putting the drops so that the
okay.
ulcer does not progress.
Okay.
Yeah, so the same coloboma, if it is a young child, congenital coloboma, you have done, then there is a small risk of amblyopia. So we generally ask to keep looking and slightly keep it open. Uh, Anyway, in those cases, the risk of the corneal exposure and cornea becoming hazy is higher than the risk of amblyopia because of the lid closure. So there is no option. We have to do that.
Yes, ma'am.
What
Yes,
is
ma'am.
the counterpart of this surgery in the lower eyelid? If
Reverse cutler beard.
yeah, what is the name for that? Well,
Uh, I don't know, ma'am.
yes, the surgery site with reverse cut is called a Hughes procedure. Okay,
Yes, ma'am.
the Hughes procedure counterpart.
Hughes procedure. Yes, ma'am. For lower lid.
Yes. That's it. So basically, in any types of upper eyelid disease, what is the duration? Like, what is the golden period to operate? Like, any
Um,
particular time that you recommend immediate or later, week after
if
that?
cornea is exposed, like we have to do the immediate repair. If the defect is very small and cornea is not involved, we can wait and watch. Like,
Correct. So many a time, although we see the bit different, patients are very worried because of bleeding, and why it bleeds because your orbicularis is a circular, and whenever there is a tear vertically, the circular orbicularis gapes. Okay, so it
yes,
looks very bad, but most of your lid injuries heal very well, and cosmetically they are very good, and they're very forgiving also. So, if the patient is convinced that if you can convince the patient it's not an emergency, whenever the cornea is not involved, you can do the lid repair at a later date also, like the next day or the next day. More importantly, whenever there is an injury, it is very important for us to rule head injury. Okay. Sometimes when there's a road traffic accident, some serious injury, so we shouldn't rush to do the lid tear repair, but first rule out any systemic problem. If there is a systemic condition, that has to be treated first. Your lid tear can always be repaired later. However, if the cornea is exposed, it has to be taken care of. Suppose since we are dealing with this problem, if there is canalicular tear, what is the time the repair has to be taken? Would you take it immediately or would you take it after some 2 or 3 days?
canalicular tear, we have to take up immediately.
Okay, if you take it very immediately, it's very good. Like if the patient presents 1 hour, 2 hours before the tissue swells, more likely that you get the chemical. But most of the time, patients present later to us. So that by that time, the tissue edema would have set in. So it is hard to find the canal. Such
Oh, yes, ma'am.
cases, we give them steroids and for 1 or 2 days, and once the tissue edema is subsided, then the chances of finding the canal is higher. Okay.
Yes, ma'am.
So I think we have covered the timing of the procedure for the lid tear, and whenever the injuries are smaller, direct approximation works well. Whenever
Yes.
there is tissue loss, we decide based on the location and the amount of tissue loss. So, can you just summarize for a medial, what is the procedure? Middle, what is the procedure? Lateral, what is the procedure?
Sorry, ma'am, your voice has broke.
No, what is the procedure of choice for medial defect, middle defect, and lateral defect?
Uh,
Can you hear now?
yes, ma'am.
So I was just telling you, to conclude the session, can you finally summarize what are the surgeries for a medial defect, middle defect, and lateral defect?
So, for medial defect, we can take the paramedian forehead flap and glabella
Yes,
flap.
yes,
For lateral, we can do this tensile semicircular flap.
yes.
Uh, for
For the
middle,
middle, you
like
can do the cutler bed flap.
cutler blade.
Yes. Okay, I think that is enough. And one thing is like in an unconscious patient, lid has to be covered. In an ICU setup, whenever you guys go for, when they call neurosurgeons, call you to check, you
Yes.
please ensure that the lid is closed at all times so that they don't land in exposure keratopathy. Okay.
Okay.
Yeah.
Okay.
Okay. I think we can, Deepthi, can we finish this? We have taken almost half an hour.
Yes, ma'am. Sure, ma'am.
We can move to the next case.
Yes, ma'am. Thank you, Dr. Shruti.
Thank you, ma'am.
Wonderful case presentation. And thank you, ma'am, for moderating this session despite the hectic schedule. So now I would like Dr. Dhaneshwari, can you please share your presentation, unmute yourself, share your PPT, put it on the slide share mode. And I request Dr. Sheetal, ma'am, the next case would be case of anterior uveitis to go ahead with the next case presentation. Dr. Dhaneshwari.
Good evening, ma'am. Am I audible?
Yeah, you're audible.
Hello.
Yeah, good evening, Dhaneshwari. You're audible.
Uh,
Can you go to slide share?
yes,
Yeah.
ma'am.
Okay.
So good evening, ma'am. So I am presenting a case of Mr. K, a 45 years old male. He is software engineer by profession, and he is a resident of Bangalore. He presented with the chief complaint of redness and blurring of vision in the right eye since 1 week. History of the history of presenting illness. The patient was apparently asymptomatic 1 week back when he developed redness in the right eye, which was associated with blurring of vision for both distance and near, which was associated with watering, photophobia, and the watery discharge. There was no history of any skin conditions like hypo or hypopigmented rash, maculopapular rash, or erythema nodosum, or plaque type of lesions. No
Dhaneshwari,
associated
one
GI
second. I'll just interrupt you here. As you're telling me the negative history, I would just like
Yes, ma'am.
you to tell me why you have asked a particular thing with what in mind. Okay.
So, ma'am, actually, for the skin conditions, hypopigmented rashes, I asked to rule out the condition like we can see it in leprosy, as leprosy is also associated with anterior uveitis, and maculopapular rash for the syphilis I asked, and erythema nodosum for to rule out sarcoidosis, and plague type of lesions for to rule
Okay, so
psoriatic
this is something you're asking the
arthritis.
patient, right? Am I right?
Yes, ma'am. Yes,
Okay,
ma'am.
so aren't these terms a little technical?
Yes,
Okay,
ma'am.
you've used so many technical terms here. So please remember that it has to be in because you're asking the patients, right? So use
Yes,
simpler
ma'am.
terminologies that the patient can understand. Okay?
Sure,
Yeah.
ma'am. Sure,
You
ma'am.
can continue. So just give it a
Okay, ma'am.
thought and then simplify it. Just remember this for your exams. Yeah. Okay.
Thank you, ma'am. Okay, ma'am. I will take a note of it. And there were no GI conditions associated, like dysentery or altered bowel habits, and there was no history of
So
mouth
why did you
ulcers.
think, what were you thinking when you asked history of dysentery or
Uh,
altered bowel habit?
Ma'am,
Anything? Mm.
yes, ma'am. Actually, dysentery and altered bowel habits can be seen in Reader syndrome, ma'am. So to rule out that, I asked.
Yeah.
Uh, then,
All right.
there was no history of urinary discharge or blood in the urine, and uh, then there is
Ulcers suggestive of which condition?
mouth ulcer. Sorry, ma'am. This dysentery and altered bowel habits was for this ulcerative colitis and Crohn's disease.
Colitis.
Sorry.
Okay.
Crohn's
Associated with
disease,
it. Yeah.
inflammatory.
Okay.
Yes.
Mhm.
And mouth ulcers for to rule out Behçet's disease or any Behçet's disease, ma'am.
Yeah. Behçet's disease. Recurrent mouth ulcers. Okay.
Yes, ma'am.
What else?
And urinary discharge and blood in the urine to rule out urethritis as seen in Reader's syndrome, ma'am. And I asked, there was no history of fever, cough, weight loss to rule out tuberculosis, ma'am. And
Okay.
no history of trauma to rule out the traumatic
Okay.
uveitis.
Okay.
And no history of floaters or flashes of light
Mm. Why did you ask
to
that
rule out
history?
any spillover uveitis, ma'am.
Flashes of light in uveitis?
No, ma'am. Only floaters should be there.
Okay. All right. Go ahead.
Past history. There was a history of similar episodes in the past for which the patient was given topical medication, but he does not have the details of it. History of joint pain is present for which the patient is taking etanercept injections and tab etoshine.
Okay. Didn't you want to ask
Uh,
history of more history of joint pains? Because what might we be interested? Which type of joint pain?
Joint pain as like low back pain or low back pain or cervical pain or it is usually associated in spondyloarthropathies we see
Mm.
and
What else? Are you
and
interested in larger joints like the knees or the smaller joints? Which one are you interested in with this
mostly
patient
the
profile?
mostly like eggshell skeleton only, ma'am, the larger joints.
Why not smaller ones? Aren't you interested in the history of rheumatoid arthritis? Is that also mainly
Ma'am,
the axial skeleton, the joints there?
uh, it mostly that will be of smaller joints, ma'am.
Yeah, exactly. And you have to ask little more history, whether it was associated with pain, redness. Okay. This is a 45-year-old.
Yes,
Had it to
ma'am.
be a little older and osteoarthritis, or sometimes even in youngsters, you may get early degeneration and osteoarthritis. Are you interested in osteoarthritis? No.
No,
Is
ma'am.
that commonly associated with uveitis? It's not. Okay.
Yes.
So that is
Hmm.
something
Yes,
you
ma'am.
have to elaborate. What kind of joint involvement?
Hmm.
Okay.
Yes,
Yeah.
ma'am. Yes, ma'am.
Okay. All right.
So, coming to medical history, the patient has nil systemic illnesses. Personal history, the appetite was normal. Sleep was disturbed due to the eye pain. Bowel and bladder habits was normal, and he doesn't have any addictions. There is no significant family history.
Okay.
General physical examination. He is a middle-aged male, moderately built, conscious and cooperative, oriented to time, place, and person. His pulse is 82 beats per minute. BP is and rest all general physical examination is within normal limits. Systemic
Okay,
examination.
I want you to just elaborate a little more on general physical examination. Okay, what are the things you want to look for? I think you have gone through it very quickly. I would like you to spend a little more time. What are the things you'd like to look for?
Generally,
So you
from
have
head
given
to
those things in the history, okay, wherein you took those technical names, no? This is where you
yes,
have to look for those findings. So tell me, what all will you look for?
ma'am. First from hairs we should look for
Yes.
alopecia, any
Hmm.
poliosis we should look for, and
Okay,
then
which
on the skin we can
condition would
look
you
for
get poliosis, madarosis?
uh, um, ma'am, VKH, ma'am.
You get poliosis
Uh,
there. Okay, good. Then
then, ma'am,
madarosis, which
then
systemic condition? You have mentioned it earlier.
syphilis, ma'am.
Syphilis or the other one?
Yeah.
Leprosy, you said, no? Madarosis
Uh-huh.
associated with
Leprosy.
uveitis. Okay, commonly found there. Then what else?
Then, ma'am,
Where would you
on the
get
skin, all the
rashes? Hmm. Rashes or
rashes we can.
scars? Hmm.
Rashes, ma'am, like maculopapular rashes, we can get in a secondary stage of syphilis. Then erythema nodosum like rashes, we can get in the sarcoidosis. Then, um,
Okay.
uh, and then we have to
Psoriasis.
look for other
Can you have uveitis that's
psoriatic
associated
plaques.
with psoriasis? Yeah, you would like to have a look at the nails also. Okay, so
Yes, ma'am.
lymphadenopathy.
Pitting signs.
Is there any importance of lymphadenopathy in the case of examination of uveitis?
Ma'am, hilar
Of course.
lymphadenopathy,
Which
we have to
conditions?
check for. Ma'am, sarcoidosis we
Hilar,
have.
why directly hilar? Local
S-
lymph nodes? Yes or no? Which uveitis maybe, which infectious uveitis will you get involvement of lymph nodes? Not a very difficult question. At least one you tell me. Infectious. Hmm?
Sorry, ma'am. I don't
Tuberculosis?
know, ma'am. Sir.
Okay.
Yes.
At least
Mm.
tuberculosis. Keep thinking of that every now and then because it can give rise to almost everything in the eye, right?
Mm.
Okay. And one
Yes,
more
ma'am.
thing, see, when you have a case like this, let's discuss this as a painful diminution of vision of short duration in a young male. So let's not assume it
Mm.
is uveitis right away. Okay, you will get very biased. You might end up missing
Mm.
a couple of things. Okay. So it could
Yes,
be a
ma'am.
case or it could be a masquerade syndrome. You're thinking it is uveitis. So examination of lymph node becomes again important. Okay.
Yes,
So keep
yes,
your
ma'am.
mind open when you're initially doing the history and the general physical examination and systemic examination also. Okay. All right. Is the
Yes, ma'am.
history of this thing sexual exposure important? History of contact? Did you ask?
It's important, ma'am.
Yeah.
It's
So
but
you have to
it's
ask.
important.
Okay. Yes, it's very
Yes,
important.
ma'am.
You ask for history
Mm.
of mixed diet. Okay. With any particular reason you asked? Could there be an association with uveitis?
Mixed diet can be for ma'am
Good. Hmm.
toxoplasmosis, ma'am.
Toxocara, toxocara also. Okay. Because
Yes,
maybe
ma'am.
that gives rise to intermediate uveitis or posterior. Okay. So that is
Yes,
important.
ma'am.
All right. Continue.
Yes. Then coming to
System.
the systemic examination. Central vascular system was normal, the normal in within normal
Central
limits.
vascular
CNS
system,
exam,
cardiovascular
central
system.
vascular system. Sorry, cardiovascular
Yeah.
system
You
was
relax. Examiners are not scary. Okay. You relax and answer. Aram se.
the card.
Hmm.
The cardiovascular system,
Hmm.
S1 and S2 was normal and no murmurs was heard. The central nervous system, no motor and sensory, normal motor and sensory system, and higher mental functions were normal. Uh,
Hmm.
and then respiratory system was normal and no added breath sounds, but abdominally
Okay,
soft and
fine.
non-tender, and no organomegaly was noted.
Okay.
Ocular examination. Head posture was normal, facial symmetry normal, ocular alignment was normal, and ocular movements full range and free in all cases. Uh, Ocular examination on slit lamp. Right eye examination. The uncorrected visual acuity was 6 by 24, which was not improving on any addition. The eyelids were normal. Conjunctiva showed the circumcorneal congestion. Sclera was normal, and the cornea showed small to medium sized white keratic precipitates present in the distribution of Als triangle. Anterior chamber showed flares 3 plus and cells 4 plus. And iris, there was a presence of posterior synechia. Pupil was festoon shape and the lens was clear. In the coming to the
Okay.
left eye ocular
One
examination.
One second. Okay. So, in PG exams, we generally expect that you describe the findings. I know you might find that it is very, silly, but many examiners do expect that. So, can you tell me how will you describe this posterior synechia that is present? Just
Uh,
describe simple thing that
posterior.
you have the photograph, no, with you.
Yes, ma'am.
Yeah, you have to describe it little more. Yeah.
Ma'am,
Because many times this image patient may not be there with the examiner. So I have to imagine when you describe it. So describe it in that particular fashion.
ma'am, posterior synechia, they were present at 2 and 7 o'clock hours. And
3 I can make out, no? At 2 and between 6 and 7 and 1 almost
7.
between 8 and 9. Correct?
Mhm.
Yeah.
Yes, ma'am.
Describe little more. Describe little more. Are they
And
very narrow? Are they broad?
they are not narrow. They are narrow paced.
Okay. And why do you think that is important? The
Ma'am,
description
because
of Sainike, will it help us? Will it give us
yeah,
any more information?
ma'am, because we usually see broad-based posterior synechia in the granulomatous uveitis, and
Yes,
that's why.
correct. Okay,
Mm.
all right. Then you have not described the anterior chamber in detail. Can you describe it a little more?
Um, Anterior
Yeah.
chamber, ma'am.
Hmm.
Anterior chamber, ma'am. The depth was
Yeah.
the anterior chamber depth was normal, and
Okay, now I'm not happy with that. You have to describe it a little more.
uh,
Peripheral and central. Okay, tell me how will you look for peripheral anterior depth, anterior
ma'am,
chamber depth? Yeah.
Von Erich's grading with the
Okay.
Von
Do you
Erich's
know how
grading.
to do it?
Yes, ma'am. We have
Yeah.
four grades of Von Herrings.
That is grading. How do you do it?
We make a slit and we
Hmm.
place it on the limbus, at the limbus, and
Which limbus?
temporal limbus, ma'am.
Okay.
And
And
we
then?
compare the breadth of the slit with the anterior
Hmm. Good.
uh,
Go ahead.
uh, with the thickness of the anterior chamber.
Okay. Would you use the term thickness of the anterior chamber? Is that the right term?
The depth of the anterior chamber.
Okay. So you know the grades. Okay. Which one is narrowest? 1, 0, 1, or 4?
Ma'am, 1 is the narrowest.
Okay. Fine. All right. So, and what about the central anterior chamber?
Uh, center we
Well, look
center
at your findings. You may get a clue from that. Is it deep in the center and slightly shallow in the periphery? Is it uniformly deep, uniformly shallow? What would it be? You said synechia present.
If there is if there are if there are any synechias are present, then the chamber will be not uniformly uh,
Correct. So it's of irregular depth. Okay. So where is it
the
deep
regular
now? It's deeper in the center.
center.
Okay. So you must describe the anterior chamber in this manner. All right.
Yes, ma'am.
Okay. I am also wanting to look for more findings in the iris. I'm not satisfied with just one finding.
Uh,
In the
I,
case of uveitis, what all would you like to look for in the iris?
ma'am, we have to look for the texture of the iris, its
Texture,
pattern, and
you feel texture, correct? So texture is not the right term. What's a better term to use?
the
You were saying loss
pattern
of
of
pattern of the iris.
pattern
Okay.
pattern
What
of the
else?
iris,
Hmm.
and then whether any atrophy is there or not, or
Okay.
then we have to
Can you
look for
tell me
any.
one or two conditions where you'll find iris atrophy in a case of uveitis?
We see segmental iris atrophy in case of herpes simplex, uveitis, and diffuse
Okay.
and zoster.
Okay.
Then,
Fine. What else? What are the other findings in the iris?
then we can see nodules, ma'am, like
Very good.
Busaka nodule
Can you
and
name them?
Kopes nodule.
Hmm.
Busaka nodule
So,
and Kopes
what is the
nodule.
location of the Skepes nodules?
Ma'am, Kopes is at the pupillary margin, and
Okay.
Busakas are at the stoma near the
Okay. So,
vulva.
what is the importance of looking for these nodules? Does it give you any information of regarding what type of uveitis it might be?
Ma'am, Busaka nodules are mostly seen in the granulomatous uveitis.
Yeah. Okay. Generally, nodules are seen in granulomatous uveitis. Okay. Any more findings in the iris? I'm still not satisfied.
And ma'am, we can see if any neovascularization is there,
Very good.
and
Okay.
we can look for
Could
occlusio
normal
pupillae.
vessels also be there which are prominent
Yes, ma'am. In
in,
case
say,
of
chronic
Fuchs,
choroidocyclitis? Yeah. So,
in Fuchs,
how
the
will you
neon.
differentiate? I'm confused whether it's a new vessel or whether it's a normal vessel that is now seen very well. How to differentiate?
New vessel will be very fine and irregular, and like
So, I
and
expect you to use some classical terms to describe that. Hmm.
ma'am, it will be florid and
Noted. Okay. What else?
uh on ma'am actually on fluorescent we can do, they will leak on fluorescent angiograph.
Fluorescein, no, we are just doing clinical examination. You are an ophthalmologist in a primary center. You may not have FFA. So, just based on your clinical skill, I want to know what is your diagnosis. Okay. So, how just looking at the slit lamp, how will you make out? What are the features?
Uh,
How do normal vessels look,
normal
appear?
or Normal will
So
be,
if
ma'am,
these are superficial, they have a lot of branching, then what is the appearance of normal vessels that might be seen in a case of chronic uveitis?
sorry, ma'am, I
What is
don't
their
know.
direction? Okay, doesn't matter. We'll go to what you know. Okay. So, what would you like to see in the lens in a case of uveitis? You said this previous episodes, no, this patient had. This is not the first episode. Okay. So,
Yes,
what are
ma'am.
the findings in the lens you might be interested in?
Ma'am, the lens can develop complicated cataract.
Okay. And how do you know that it's a complicated cataract? What are the features suggestive of that?
Uh, they usually present with, ma'am, posterior subcapsular cataract.
Okay. Location. Okay. Fine.
Uh,
But that doesn't tell me it's complicated, no? You can otherwise also age-related cataract can be posterior subcapsular location. So what are the clinical features that will help me identify immediately, okay, this looks like a complicated cataract? What do you have for breakfast?
uh,
Hmm? When you're in a hurry, you make a sandwich, no? What do you make a sandwich with?
bread, ma'am. Bread.
Ah, yeah, now tell me. There is?
Breadcrumb appearance.
Yeah, breadcrumb appearance. Okay, what else? Any other feature is there to identify a complicated cataract? What other appearance?
There might be some iris pigments over the anterior lens capsules.
Okay, what else?
Uh,
What else? You like colors? Are you a colorful person? Hmm?
then polychromatic luster.
Yeah, see, I'm asking you very, very simple questions, okay? You perhaps read for very tough ones, but I'm interested in simple things. Okay, so these
Yes.
are the things. Is there any other reason that the patient could have a lens opacity? I agree it could be a complicated cataract. Okay. Is there any other reason? You said patient is having repeated episodes. He was using some drops. Okay. I don't know if he was using something systemically also. So could there be any other reason for this opacity in the lens?
Next, if he was using any steroid for his treatment, then
Yes. So it could be a steroid induced
steroid induced.
cataract, isn't it?
Yes, ma'am.
Okay. All right. So continue your examination.
Uh, Coming to the left eye examination, he has a uncorrected visual acuity of 6/6. The eyelids was normal,
So
conjunctiva normal.
everything else was normal in the left eye, correct?
Yes, ma'am.
Okay. Would you like to do any other investigations on the anterior segment, if possible, if the patient doesn't have too much pain? You have left some one or two important things.
Yes, ma'am. I would like to
Hmm.
do one IUP measurement also for
Very
the
good.
right eye.
Very important also. Okay. Why do you
Yes,
think IOP is important in a case of uveitis?
because uveitis does lead to trabeculitis in certain cases, and eventually there is raised IOP.
Okay.
So, so
So tell me the other different mechanisms by which it can give rise to glaucoma.
one is the trabeculitis, other is the inflammatory cells themselves can block the trabecular meshwork, and
Okay.
then again one the long-term steroid use, and
Okay.
then
So all
if it
these
is
are open angle types. Is there any scope for secondary angle closure?
yes, ma'am, if there is a
Ah,
posterior
yes, yes. Hmm.
synachial peripheral
Yes. Hmm.
if there is seclusion pupillae, ma'am. if there is occlusio pupillae, that
Okay.
can lead to
So what
that
happens?
can lead
What is seclusio pupillae, and how does it give rise to a secondary angle closure glaucoma?
occlusio pupillae is a uh, ring. It's
Good.
a it's
Hmm.
a 360-degree uh,
Ring
ring peripheral
Synechiae. Ring
synechiae.
Synechiae.
Yes, ring
Okay. So
synechiae.
what happens? Okay.
So
So
it
this is
will
between
eventually
iris and the lens. So how does it give rise to a secondary angle closure glaucoma?
so it will lead to iris bombay formation, and
Okay.
eventually it can lead to the closure of the angles.
Yes. Okay.
Huh.
Then what is a total posterior synechiae? How is it different from a ring synechiae? Yeah. How will you identify it clinically? A total posterior synechiae. In case you're not sure, you can tell me because then I'll move on to the next one. But I will hope that
I'm,
you will go through the theory. Yeah.
no, I'm not sure. I will go through.
You're not very sure what is total posterior synechiae. The AC is not shallow like this, like it is when you have a ring synechiae, where the entire iris is adherent to the underlying lens. Okay, so read up a little more about this. Seclusio pupillae, occlusio pupillae, and total posterior synechiae. These are the things that you familiarize yourself with. Okay.
Hmm. Yes, ma'am.
So, is there any role of gonioscopy then in a case of uveitis?
Yes, ma'am.
Yes.
Know
Mm.
the whether it is open, close, or whether any neovascularization of angle is there to see all these things.
Mainly, like you said, no, if there's synechiae and all that peripheral anterior synechiae,
Yes.
we come to know. Okay, any pigments are there. All right. So now, how do you want to manage this case? Now you have all the Actually, fundus have you seen, or you're only expected to tell the anterior segment findings?
I was given fundus.
Okay.
This also I was given. So
Okay.
right eye
So I
fundus.
would like to know that what is it that you would like to look for in the fundus in such a case? It's normal here, but what are the things you might be interested in?
Uh, Mostly, ma'am, if it is a recurrent, uh, if it is a recurrent acute uveitis, it can lead
You
to.
don't know. You don't know right now whether there is intermediate or posterior, isn't it? So if you want to rule that out, what are the signs you look for to rule out posterior uveitis or intermediate uveitis?
For snowballs, opacities, and
Hmm.
snow banking, and we have
Hmm.
to
How do you
rule
look
out.
for that snow banking?
Ma'am, we have to do a indented peripheral examination and look
Hmm.
at the inferior aura. There we
Hmm.
mostly we look.
Do you know how to indent the peripheral retina or the pars plana? What do you use to indent?
There is a scleral indenter that we use.
Scleral indenter. Okay. All right. Also, thimble. Hmm? So there are different types. So just familiarize yourself with what is normally used in your place.
Yes.
Okay. So you're going to look for snow banking, you said. What other things?
Then, ma'am, we have to look out for vitritis if any vitritis is there,
Very good.
and
So I expect you in the anterior segment itself, after the lens, you have to comment on the vitreous. How much of vitreous can you see on slit lamp?
anterior vitreous phase, ma'am, we can
Yeah,
see.
anterior 1/3 of the vitreous. And you also have to grade it. Okay.
Yes, ma'am.
Okay. So you want to look at the vitreous. Do you want to look at the vessels also? You
Yes,
get
ma'am.
any vascular signs? Yeah.
We have to look for any vasculitis and
Yes. And how do you know there is vasculitis? What is the sign?
ma'am, we have to look for any sheathing is there around the vessels,
Okay. Mm-hmm.
and then
Okay.
we have to look for any retinitis or choroiditis, if it is there or not,
Okay.
to rule out posterior uveitis.
Okay. So anatomically, how do we classify uveitis?
Anatomically, it is divided into anterior uveitis, intermediate, posterior, and panuveitis. Anterior is when it involves the infection, when inflammation is in the anterior chamber.
Hmm.
It involves
Anterior chamber. You tell me which uveal
uh,
structure is involved.
it involves iritis and iridocyclitis, and intermediate is when it involves pars planitis, posterior cyclitis, and highlitis.
Posterior
And
cyclitis, pars planitis.
yes, ma'am. And posterior is when it involves retinitis, choroiditis, retinochoroiditis, chorioretinitis, or neuroretinitis. And panuveitis is when all the three are
So you
involved,
have
ma'am.
to refine this a little more when you answer. Okay. Go through
Yes, ma'am.
the, yeah. So, okay. So now what else do you want to do? Now you've examined, now you think it is anterior uveitis. Okay. What else
Yes,
do you want to do now? How do you want to investigate this case? Would you like to leave it because it is anterior, or would you like to investigate it?
would like to investigate, ma'am. I would like
Okay.
to investigate. So I would like to send the some systemic investigations for complete blood picture, a complete blood count, along with the ESR and CRP, along with the uh, this serum ACE levels, and along with the serum TPHA level, THPA levels, and along with I would like to do
TPHA.
TPHA levels. Along with that, I would like to do a Montauk's test for the patient, and and or a X-ray chest for the
Okay,
patient.
now you have to tailor your investigations. Okay. Because if you're thinking in terms of granulomatous uveitis, then all the tests for tuberculosis, sarcoid, and all that becomes relevant. Okay. If you're thinking of a granulomatous uveitis, then perhaps your investigations would be a little different. Okay. So when I asked you these questions, you have to tell me what is in mind and what for you're asking these certain investigations.
Yes, ma'am.
Okay, so you have put everything together.
Okay.
Okay, so
So,
you can curate your answers. Yes.
ma'am, CBC and ESR CRP generally, because it will be raised in, they are acute phase reactant, generally will be raised in any systemic, any inflammatory conditions they are raised. And then,
So which inflammatory conditions are you thinking in him?
ma'am, I am thinking of like spondyloarthropathies.
Okay.
So for that,
Mm.
then
Mm.
I would like to send for HLA-B27.
Yes. Mm. RA
So,
factor, ANA,
uh,
all those kind of investigations you want to
yes,
send, no?
yes,
Immune.
ma'am.
Mm. Okay.
Uh,
So rarely it can perhaps happen that, tuberculosis, this, that, but when you answer, if you classify and answer, it's more impressive. And remember, with minimum investigations and with more of your clinical acumen, you must try and make a diagnosis and treat patients. Okay, because in the primary center, you may not have access to so many investigations, right? So I want to
yes, ma'am.
see if at a primary center, you are able to diagnose and give the basic treatment to this patient. Okay,
Yes, yes, ma'am.
all right. So you've done your battery of investigations. Now I would like to know how you're going to manage the case.
Ma'am,
Local investigations include also, would you like to do a OCT if it is available? Because you told all these systemic investigations. So see what
yes, ma'am.
local investigations you can do if you have the facility. All right.
Yes, ma'am.
Okay.
Yeah,
Now
ma'am.
let's
OC.
go to the treatment. Let's go to the treatment.
So, ma'am, for treatment, I would like to start this patient on topical steroids, and along with that, I would like to start him on the cycloplegics. So, topical
Okay, now
steroids
an
will cause.
undergraduate will answer like this. I'm going to cut you short here because as a postgraduate, you should tell me what steroid you want.
So,
Okay,
ma'am,
name the steroid. Don't say just
ma'am,
antibiotic, steroid. Okay.
prednisolone,
Yeah.
topical prednisolone 1%, uh,
Yes. Hmm.
and then it can be started in like 6 times a day
Hmm.
for a week, and then like we can follow up the
Would that
patient
depend
and
on how severe the
see.
uveitis is?
Yes,
Yeah.
yes,
So how
ma'am.
severe
Then
do you think the uveitis is in this case?
in
Mild,
this
moderate?
case, uh, in this case, the AC flare was 3+ and cells were 4+, ma'am. So it is moderate, ma'am.
Okay. So
Moderate to
because
mark.
it's moderate, you would like to start 1% prednisolone acetate suspension 6 times a day. Correct? That's what you want to say.
Yes, ma'am.
Correct, no? Okay, fine. Then next.
Then next, I would like to give cycloplegic like homide eye drop 2 times a day
So
to
how much
prevent
Sinike is there, no? Thick Sinike. Would you like to give something better than homide?
atropine 1%
Yeah,
ion.
that is the strongest cycloplegic, isn't it? I
Yes,
would
ma'am.
perhaps prefer that. Okay.
Yes, ma'am.
Hmm. Okay.
So
How frequently do you want to give
ma'am, we can
atropine?
give twice a day. We can give, ma'am.
Which one would you prefer, drops or ointment?
Ma'am, ointment.
Okay. Why do you think ointment is better?
Uh,
Why not drops?
ma'am, it's uh, bioavailability will be better, ma'am.
Bioavailability, you mean? Why? Drops also, I'm sure absorption is okay. But what is one problem with drops, which you may not have so much in with ointment? What happens? Let's say patient is confused. He put 6 times atropine along with your steroid. You've not counseled
Uh,
properly. What
so,
will
ma'am,
happen?
he can confuse the atropine eye drop with the and
That's not the reason we are giving ointment. What will happen to the drop if you don't ask to do punctal occlusion and all that? What will
systemic
happen?
systemic
Atropine.
absorption. Systemic
Systemic
absorption will happen.
absorption, isn't it? You know what first pass metabolism is? Why
Uh,
this systemic absorption takes place and give rise to side effects so easily? Okay, you can read up about that. Okay.
yes, ma'am.
And what is one disadvantage of ointments in general? Why we don't give ointment so much daytime? Sometimes we say nighttime ointment, daytime drops. What is the reason for that? What can happen to the vision when you use ointment?
Ma'am, because ointments are they are sticky and they can
Hmm. They can cause blurring, no?
blurring. Yes, ma'am.
Yeah. So that is one disadvantage. Okay.
Yes, ma'am.
All right. So you've done with cycloplegic, you're done with steroids. Okay. Let's say it's not helpful. How will you step up the management?
Uh, after that, ma'am, if it is not resolving, then we can give the patient oral steroids. We can give, ma'am.
Hmm.
So I would like to give according to his weight,
Hmm.
uh, 1 mg/kg body weight of pre- uh,
Would you
Vicelon.
consider anything before that? Because it's unilateral. Would you directly go to systemic steroids? Generally, when would we prefer systemic steroids? Is there any
Systemic.
role of periocular steroids?
How, ma'am, we can give subtenons injection, posterior subtenons injection. We can give
Yeah.
that also. We can give.
Hmm.
Uh,
Okay. Then
um,
Now you said patient is getting recurrent attacks. So will you keep giving, and let's say he's a steroid responder, you can't give him periocular injections.
Hmm.
Okay. Will you keep on giving him systemic oral steroids?
No,
What will
ma'am.
happen? Hmm.
Then he will
He'll have a
he
side
can
effects due to systemic steroids.
steroid.
So many of them are there. Okay. So
Yes,
then
ma'am.
what to do? Does he have any other alternatives? He's not
Yes,
very
ma'am. We
happy
can.
with the side effects of steroids. He'll start putting on weight, Cushingoid syndrome will start, features. So what is the other option?
We can give ma'am immunomodulators like the steroid sparing agents. We can start him on
Hmm.
uh, like methotrexate or
Yes.
other drugs like TNF
Yes.
blockers.
Hmm.
Those kind of
So
medicines we
generally,
can.
for more than 3 months, they require the systemic steroids. Then we prefer to put them on immunosuppressive medication. So it's very important to screen the patient before you start either steroids or this immunosuppressive treatment. Okay. And
Yes,
also
ma'am.
one very important thing, what should you counsel the patient when they're on immunosuppressives? Is it okay if he comes to you once a month, once in 3 months like that? Or will you call him more frequently to look for something?
Uh,
Will you ask any investigations time to time?
yeah, ma'am, for their complete blood picture should be done
Yes. Yeah.
because
So
that's
depending on the drug, no, you have to do regular
yes,
CBC,
ma'am.
maybe
Yes, ma'am.
LFT,
Yes,
RFT.
ma'am.
So you have to keep that in mind. Okay. And sometimes there are very specific toxicities. Keep that in mind.
Yes, ma'am.
Okay.
Yes, ma'am.
Okay. Then any other drugs? These are the typical immunosuppressors. Any other immunomodulators, you know?
Ma'am, infliximab, etanercept,
Mm.
and adalimumab.
Yeah. Tumor necrosis, anti whatever, tumor necrosis factor alpha. Those drugs, adalimumab, I think these are
Yes,
all
ma'am.
now having important role in the treatment of uveitis. Okay, so now one of the favorite questions of examiners. Okay, in a case of chronic anterior uveitis, what are the different causes because of which vision can be diminished from anterior segment to posterior segment? You can go. What are the different reasons for diminution of vision? Start from the cornea.
Ma'am, band shape keratopathy, and
Okay.
then uh, there's occlusio pupillae can be there. Then
Okay.
cataract can be there.
Okay.
Then cystoid macular edema, and
Okay.
then
Glaucoma.
glaucoma. Yes,
Mm.
and eventually, yes,
Mm. Can go into phthisis.
phthisis, phthisis bulbi.
Okay. All right. So now, in fact, uveitis, I can perhaps go on and on, but generally, you're asked very simple questions. Okay. So make sure that, you don't bungle up in that. Because whatever is very complicated, newer drugs, newer investigations, we won't be so much interested in that. We are interested in the basic thing. Like I'll ask you, how do you grade cells and flare? How do you look for it? What's the magnification? What's the size of the slit? Okay, what is this arched triangle? What are
Yes, ma'am.
KPs made up of? Okay, how do you differentiate old KP from new KPs? How do you identify a complicated cataract? So these are the kind of questions that at least me as an examiner would ask. Okay.
Yes, ma'am.
So, and always classify whatever you answer. A good way to do it is to classify like infectious causes, non-infectious, anterior segment, posterior segment. So that way, divide, always classify and answer. That becomes more impressive. When I asked you for negative history, also same thing. Think of the
Yes, ma'am.
condition and then say, what you're looking for. Investigations also, with what in mind you are asking for a particular investigation. Don't try to mix up the infectious, non-infectious causes. All right.
Yes,
So these are
yes,
some
ma'am.
of my suggestions to you. I think
Yes,
you
ma'am.
perhaps must have prepared very well. That's why my basic questions must have rattled you a little,
No, no.
isn't it? That is over preparedness, perhaps. Okay. But remember, it's always going to be very, very basic. Hmm?
Yeah, thank
Anything
you.
that, yeah. Think of masquerades also. I didn't touch upon that. Never assume that it's always a straightforward case of uveitis. It could always be a masquerade. You know what a masquerade is, right?
Yes, ma'am. If any malignancy is there associated.
Yes.
Yes, ma'am.
Yes. So, okay, I think I'm done. Deepti?
Thank you, ma'am. I think ma'am has covered the whole of Khurana and Parsons uveitis. I started to remember my ophthalmology days. So, but then I think three questions. Number one, ma'am has asked you to find out total Synechia and the ring Synechia, the difference between the different type of Synechia, the difference between the normal vessels as well as the abnormal vessels in the angle, the NVIs. So I think these are few questions which Daneshwari you didn't answer and you're supposed to find out, and you can message back to ma'am. And
Yes,
the
ma'am.
first
Yes, ma'am.
sentence which she mentioned in the beginning of the case presentation, that you already knew it was a uveitis, so you directly went into the uveitis proforma. She said, think logically as a painful loss of vision case. So I think being an open-minded when you take a case becomes more important, because in exam you will not be knowing what exactly the case would be even till the end maybe. So I think these 3 points were really well taken, and thank you, ma'am, for this wonderful discussion. We have KP sir also here, and he was there throughout the discussion. I noticed he entered in the beginning of the session. So over to KP sir for his feedback now.
Yeah, I was mesmerized by Sheetal's, flow of questioning and
Same here,
a
exactly.
very
Same here, sir.
typical and a very useful discussion on the students. I think many will be benefited because case of uveitis is always something people fear because they don't know what the examiner will ask. Most of the times, it is not the intricacies; it's more about the basics, the how you examine, how you interpret, how you come to a basic conclusion. So I think what is very important is uveitis is anterior uveitis, intermediate uveitis, and posterior uveitis, and pan uveitis. So basically, ask yourself what uveitis this belongs to. You have very clear, very classical, differentiating points, and then probably you think of the etiology. It is not that you know the etiology. First, you have to characterize what is the area in which the uveitis is operating. Is it only anterior segment? Is it intermediate uveitis? Is it or all aspects of the eye are involved? Then your etiology can vary. Accordingly, your investigations will vary. So first, find out what kind of uveitis it is, so that you can tell the etiology. That is very important. Okay. See, because at the same time, you also look at, is it granulomatous, non-granulomatous? There are some twilight areas where there are some overlaps, but there are some very clear-cut distinctions between the two, and the entities are many a times are very clear-cut. So let me tell you, for people, you can actually note it down. This is very important. The anterior non-granulomatous uveitis is pretty common. Okay, anterior non-granulomatous uveitis. Okay, the most important cause of this is idiopathic. Almost 90% of patients who develop this, there is no recurrence, and most of them you don't find a cause. So idiopathic is the most common thing. Whatever you investigate will all be negative. And the next important cause of anterior non-granulomatous uveitis is, okay, infectious and non-infectious causes. The non-infectious causes are much more. So very importantly, you have what is called HLA-B27 associated uveitis. So if you have a non-granulomatous anterior uveitis, think of HLA-B27 associated uveitis. There are multiple, entities even in this. The most common is ankylosing spondylitis. Then you have Retter's syndrome. Then you have inflammatory bowel disease. You have even psoriatic arthropathy. So these are all come under HLA-B27 associated uveitis. The next is very important is JIA. Looking at the age group, especially juvenile idiopathic arthritis. So you have uveitis associated, very intractable uveitis. These kids are RF negative. Rheumatoid factor will be negative, but they will be ANA positive. So remember this. Then you have Behçet's disease. Behçet's disease is typically a non-granulomatous anterior uveitis. Then there are other minor entities like lens-induced uveitis, Okay, you have injury to the lens, you have a lot of lens-induced uveitis along with glaucoma. And some of the medications like anti-HIV drugs can induce uveitis. And the most common is traumatic iritis. When you have a trauma, you have anterior segment inflammation, which is typically a anterior non-granulomatous uveitis. But there are some infections which also cause anterior non-granulomatous. Very common is viral diseases. Viral diseases come in all forms, like herpes and leptospirosis. This is a very important question. So leptospirosis is a typically anterior non-granulomatous uveitis. Then what about granulomatous anterior uveitis? See, granulomatous uveitis is much more serious condition. And most of the time, there is a cause associated with this. You don't have the idiopathic ones. Most of them have some reason. So, and non-granulomatous uveitis are usually idiopathic, I said, but not for granulomatous uveitis. So the infectious causes are much more common, like typically herpes simplex and herpes zoster. They cause both the types, including granulomatous and granulomatous. And typically the triad, syphilis, tuberculosis, and leprosy. You can't leave them. Every examiner is very favorite of these three conditions. That is very typically. Then weak age, and sympathetic ophthalmia and sarcoidosis. So these 6 conditions, please remember: tuberculosis, syphilis, leprosy, sarcoidosis, sympathetic ophthalmia, and weak age. These cause typically granulomatous uveitis. Even the lens-induced one you can have, like phacotoxic uveitis, can be actually even granulomatous. And very importantly, you have to investigate granulomatous uveitis. You can't leave it and it can be idiopathic. So what is, when people ask when to investigate a uveitis, a first attack of anterior non-granulomatous uveitis can be left. Okay, you just treat it and you can leave it. If there's no recurrence, you don't have to investigate. But every case of granulomatous uveitis, whether the first attack or otherwise, you have to investigate. So this is something that you should keep it. But these TB, syphilis, and leprosy can masquerade even as non-granulomatous uveitis. So you can never know. Even they can appear in both in granulomatous and non-granulomatous uveitis. So please tailor make your investigations according to the event. If you are having a granulomatous uveitis, obviously your investigations will change. You need to think of these conditions and try to at least tell one investigation. Don't try to remember 50 investigations from the book. I said tuberculosis, have one investigation. Syphilis, have one investigation. Leprosy, have one investigation. Okay, sarcoid. So have investigations as per the diagnosis. I think this has been an excellent discussion on a very important topic. So I think we will stop here for today. The 2 cases have been very well discussed. Thank you, Dr. Sheetal Sabur. So tomorrow at 7:30, tomorrow is the last day of this particular series. We are going to restart it after some time again, as per the requirement, as well as the people have requested for me to have one full session on a master class on retina conditions. So we have Dr. S. Guru Prasad, our head of our VR services. He will be telling us about the all the common retinal conditions which are kept as fundus cases. So you have PDRs, you have diabetic retinopathy, retinal detachment, venous occlusions, macular holes, ARMDs. So all of them, there will be some basic questioning, line of questioning in these conditions. So how do they present? What is the fundus picture? How to actually explain the fundus picture? And what is the basic line of management? So we can have few people on the Zoom platform tomorrow, maybe around 10 to 15, so that it can be an interactive session. The rest can actually follow it up on the YouTube. If anybody is interested to join the YouTube, so please send a message to the group so that they can be sent the Zoom link so that you can actually be on the Zoom platform and interact with Dr. Guru Prasad. The rest of the people can actually watch it on the YouTube. So with this, we conclude today's session. And I thank Dr. Sheetal Sabur for having an excellent discussion
Thank you,
on the
sir.
case of uveitis, and also Dr. Chinmayi, who actually covered the first case. So thank you, everyone. So good night.
Yes,
We'll
sir.
see you tomorrow at 7:30 on a masterclass on retinal conditions for the exams. Good night.
Thank you, sir. Thank you, sir. Good night.
Good night, ma'am. Good night, sir.
Good night, Dipti. Thank you.
Thank you, ma'am.